Hello, everyone. Thank you for coming today. My name is Manita Sundar. I'm the Provincial Program Manager for the Prostate Cancer Supportive Care Program. Before we begin, I'd like to acknowledge with gratitude, respect, and humility that we are hosting this talk from the traditional homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. Before introducing our speaker, I have a few housekeeping reminders. Please be aware that this session is being recorded and all attendees will be visible on the camera. A recording of the talk will be made available on the PCSC website in 1 to 2 weeks. For your convenience, the washrooms are just out the doors here down the hall on your left. Additionally, please ensure that your mobile phones are on silent. We would like to thank Pfizer for sponsoring this event. It is now my pleasure to introduce our speaker for this afternoon, Dr. Alex Wyatt. Dr. Wyatt is an associate professor in urologic sciences at the University of British Columbia, a senior research scientist at Vancouver Prostate Centre, and a senior scientist at BC Cancer. He holds a Doctor's of Philosophy in Genetics at the University of Oxford. Dr. Wyatt's research focuses on the relationship between epigenomic alterations and clinical outcomes in patients with aggressive prostate and bladder cancer. His team has developed innovative laboratory and computational techniques to analyze plasma ctDNA and has studied thousands of patient specimens from biobanks and clinical trials. Their groundbreaking work has led to the discovery of new biomarkers that provide valuable insights into patient management and the evolution of late-stage cancer during treatment. Please join me and welcome Dr. Alex Wyatt. Thank you.
Thank you very much for the warm welcome. Today I'd like to talk obviously about genetic testing in prostate cancer, and this is something that I've spent my career focusing on as a researcher. My PhD was originally in human genetics, and straight after that I moved to Canada and started a fellowship in prostate cancer genetics and genomics, and that was 15 odd years ago. And now I'm a faculty member with a team of 25 odd trainees like I was underneath me. And we have developed tests that are now clinically available in Canada. And I think our research has influenced the way that genetic testing is deployed in prostate cancer around the world. What I want to talk about today is not really my own research, although I would love to come back and do that another time, but really about what is genetic testing, why does it matter, why do we do it, and what's happening right now in British Columbia. And please, if you have questions during the talk, sometimes I start to go on a roll and we'll just waffle indeterminately, so please put your hand up and interrupt me at any time. There's no problem, I don't get derailed. So here are my disclosures. So I do some consulting for some pharmaceutical companies with regards to how they could interpret their clinical trials where they have genetic testing results. I don't have any financial conflicts with genetic or genomic testing companies because that's where I work, and I can't be seen to make recommendations if I do any work with any genomics companies. All of the technology we develop is open source, public. Our methods, our code, our assay design is all published at the time that we write papers, and so none of that is protected by IP or behind kind of firewalls. So what I want to talk about today, obviously at its core, is what is genetic testing or somatic tumor testing, and I'll come to what those terms mean. And one thing I was just playing around last night as I was putting the slides together with a Google image generator. So I've sprinkled a few of these, and I don't know, sorry, not Google, AI image generator. I don't know if any of you have played with these over the years. It's not the type of thing we use in my research. We don't rely on AI. We use some machine learning models, but they can be fun. Here the prompt was a group of people with prostate cancer thinking about genetic testing, and I'm not sure that we need to be worried about our AI overlords taking over right now. And this was a scientist explaining genetic testing to cancer patient advocates, and for some reason I'm 20 foot tall as well. Again, I don't know why. But hopefully that's a blueprint for today. And what I want to get into is why we do genetic testing. What are we actually trying to find? How do the results that we get actually influence treatment plans if you have prostate cancer? And what is the process for testing in our province? And maybe I can also touch on that with regards to any questions you have as well. So I actually focus in my research on what we call metastatic prostate cancer, which is the disease that's spread outside the prostate gland. We focus on that because it's one of the biggest unmet needs, because there are still many men, unfortunately, around the world that die of metastatic prostate cancer, despite all the advances we've made in treatment. And so that's where a lot of my research focus is, and that's where a lot of the need for genetic testing has come from originally. So it's kind of to some extent the same as any oncology breakthroughs, any treatment breakthroughs. They tend to initially get approved in the very late setting and then moved earlier and earlier in disease as we understand the relevance for all cancer. When I first started working on metastatic prostate cancer, we had one treatment for the disease, and that was chemotherapy. One treatment beyond hormone therapy, but that was chemotherapy. And I think my granddad, who died of metastatic prostate cancer, he was one of the first patients in London to get on a clinical trial of that chemotherapy. I remember visiting him in hospital while he was getting IV chemo. But fast forward sort of many years now, and we actually have something in the range of 15 approved agents just in the course of my career. So these are all proven to extend life. So it's not the case that all patients can receive all 15 treatments, but we've gone from having very, very little in the advanced setting to having a lot of different options. And that includes different classes of treatments. So yes, we have treatments that target the hormone axis, the androgen receptor. We also have chemotherapies. And then we have genomics-driven treatments now as well that we only give when we know that you have a certain genetic change in your cancer. And some of you may also have heard of radionuclide treatments, this last category, which is kind of the newest kid on the block, which is about precision radiation in a way, like delivering radiation specifically to prostate cells. So cancer at its core is a disease of the genome, right? So in everybody that has cancer, what happens to the cancer cells is they acquire mutations that enable them to keep growing and stop dying. And the whole genome, all of your DNA, can be remodeled in advanced disease. And I've shown these images, I think, since I was a fellow, actually. I really like this kind of image as a way to just explain why cancer can be so different between people. So on the left-hand side is all the chromosomes that you should have in a normal cell. So they've been neatly lined up. They don't look like that in a cell, obviously. They're all jumbled together. But you've got all these different pairs, one copy from your mum, one copy from your dad. So they're chromosome 1, you've got 2 copies, two copies, and so on and so forth. And this person is a female because they've got an X and a Y here at the bottom right. That's what it should look like in every normal cell in your body. On the right-hand side is an example, kind of same spread from a single cancer cell. So you can see straight away that it looks so different, right, from the normal cell. And some of the chromosomes are still recognizable, but others are sort of jumbles of things mixed together. There are multiple copies of some. And if you look down at the bottom, there's kind of hodgepodges of things that are no longer even recognizable as an individual chromosome. And this is just at the macro level. You can imagine as you zoom in at the individual coding level, it's even more complex. And the reason I show this is just to illustrate that even though everybody may have cancer or everybody may have a certain type of cancer, what that cancer is like at the DNA level is intrinsically different, right? As different as we are to each other, this is kind of many, many times more different. There's no way just stochastically that you could have 2 cancers that looked identical to each other at the DNA level, because this is just so random in many regards. And I don't kind of show this as a kind of to generate fear or anything, but it's more as a explanation for why cancer can be so different between the people that are affected by it. So it's this heterogeneity, we call it, which is just a fancy word for difference, that really helps explain why some cancers are aggressive, some are not, some respond to treatment, some are not, some are slow growing, some are fast growing. And it's because every cancer and every person is different at that DNA, that cellular level. One of the easiest ways to think about this is about a therapeutic target. So whatever we target in a cell, it's coded for by a gene. And so that those new radioligand therapies, for example, they target a protein that's expressed on a cell, and that protein is called PSMA. And it's like a homing target for the radiation. So the cancer cell is expressing this molecule, and the radiation tagged molecule can come along, bind it, and then release this radiation and kill the cancer cell. But if the cancer has deleted the gene that generates that protein, then it will not express the protein and the therapy will not work. So at that simplest form, if one of those chromosomes that carried that gene is gone, then that target will not work as a therapeutic target. That's one of the simplest forms, but you can imagine this magnified at this complexity across all levels of the genome. So to step back a bit, what are mutations? I talked about variants in DNA and mutations and so forth. I like this slide because I think it illustrates it without getting overly simplistic. So our DNA is essentially a code. 4 different bases that's shown on the left-hand side here, T's, G's, A's, and C's. Every gene is coded by different combinations of these letters. And mutations arise all the time in our body, in all our cells. On the order, a few mutations in each cell every day in each of us. Most of those get repaired immediately, some of them don't, but most of them that do arise will not be that relevant. But you can see here, so this is an example sort of mutation here, and it translates kind of highlighted in text. In this particular context, the mutation would change the meaning of the word from correct spelling to an incorrect spelling. But actually, many of the mutations we identify are not actually harmful, because most of our genome doesn't contain really important pieces of information that a tiny base change would cause a critical error. Most of it is regulatory in nature or kind of not so massively affected by a single change. So actually, the vast majority of mutations we acquire throughout the day, even if they persist, will not do anything damaging to the cells in which they're acquired. But every now and then you get one that's pathogenic. And that changes, in this context, the meaning of the word, or it changes the way a gene would function, or the cell would function. So these mutations, they can be acquired throughout our life. And in fact, the vast majority of mutations in a cancer are acquired during your life, or they can be inherited from a parent. And so many of the variation that makes us each look a little bit different to each other, and to some extent behave a little bit different to each other, is inherited from our parents. And occasionally there are some variants that you can inherit that are damaging in nature. And you may have heard, for example, of the BRCA genes in breast cancer and ovarian cancer. Mutations in those genes are very commonly inherited. They can be passed from father to daughter or daughter to son, mother to son, and they predispose to breast, ovarian, pancreas, and in fact prostate cancer. Many of the mutations that so cancer at its core is a combination of your inherited variants from your parents and then everything you've acquired in that cell over your life. And of course, there are things that speed up mutation process, right? So exposures. One of the reasons smokers get high rates of lung cancer is because you're inducing higher mutation rates in those lung cancer cells every day from the exposures. Same if you were exposed to lots of pollution. So those mutation rates go up. And again, vast majority of them don't do anything, but you increase your probability that one will eventually fall in a bad gene. The same is true for many other exposure-driven cancers. For things like prostate, there probably aren't very many simple exposures that are driving high mutation rates in prostate. It's more a factor of kind of perhaps some lifestyle elements like diet, exercise, general health, but also just a function of age. And when we look at the mutations that we see in prostate cancer, most of the ones that are acquired have the classic signatures associated with just age, which is kind of number of cells that have divided and kind of slowly accruing mutations that are, so it's not necessarily a modifiable factor. So what is genetic testing and what is somatic testing? So genetic testing is typically looking for those inherited mutations, the ones that come from your mum or your dad. Those mutations are in every cell in your body. So you can actually do genetic testing if you use a blood sample, a saliva sample, a scrape from the skin, a hair follicle. You can basically use any tissue that you could get your hands on, and you could do a genetic test and look for those inherited variants because they're present in every cell in your body. We also sometimes call this germline testing because the germline is the part of your body that passes on your DNA. And then we have somatic testing. So this is when we look for the mutations or the variants, changes to your DNA that are present specifically in the cancer cell. And so to do that, we need to actually look at the cancers. So we either use tumor tissue, so typically that might be the prostate biopsy that was collected at first diagnosis. Sometimes we can use a metastatic tissue biopsy if that's available, or if there's a metastatic lesion that's easy to biopsy. More recently, we've developed methods to pull out the cancer DNA that's present in the bloodstream. That's one of the main things my lab works on. But in those two scenarios, whether it's tissue or blood-based, we're really interested in the cancer DNA there. We sometimes call somatic testing tumor testing. But these two categories of tests are important because, as I'm going to come to later, a patient with prostate cancer, especially advanced disease, needs both of them. So we need to look specifically at the cancer mutations and also at the inherited mutations. As I mentioned, those inherited mutations are present in the cancer tissue, but if we just look at the cancer, we can't see which is which. We just see them all together, right? And it's really important that we know if one of them is inherited because it's relevant for our families. So if you know that you've got an inherited variant, then you may have family members that also share that variant. And we would recommend that they get genetic counseling and perhaps be monitored more closely for cancer development. And it's a particular thing in prostate cancer because many of the people that get prostate cancer might have daughters in their 20s or 30s. And if they carry these variants, they may be at risk of breast cancer or ovarian cancer. And so, we can potentially reduce the burden of cancer on the next generation by making sure that we identify the mutations in the current generation. Is this clear so far, this kind of breakdown? Perfect. So there's another term which gets bandied around, which is genomic testing. I mention this just because you may hear this in the literature or in the news. It's a broad term. I use it sometimes as well, but it's kind of non-specific, and it sort of describes all of those tests together. People more often use it to talk about that tumor testing, the somatic testing, but it can be inclusive of both parts. But it's just another term worth knowing about: genetic, somatic, genomic. This is the broadest term here. So if you talk to a physician about that and you say genomic testing, it kind of can refer to either of those classes. So just to kind of hammer home this point about the different origins of mutations, BRCA2, which is an important gene that I'll refer to a few times over the next period. These mutations, they can be inherited from a parent, or they can be only in the cancer. What's important is the cancer cell doesn't care. Right? In both of those situations, the cancer cell has been able to disrupt a gene that was preventing it from growing or able to help it accelerate. The origin of the mutation doesn't matter to the cancer. So it matters to us because of the reasons I mentioned for familial implications, but from the cancer's point of view, it doesn't matter. The reason why people with these types of variants are predisposed to, please come in. The reason why people are predisposed to get cancer a little bit younger than somebody who doesn't have these variants is because what you typically need is a mutation on both copies of the chromosome. And so you inherit one mutant version from a parent, and then your other copy is functional. But as you get older, by chance, eventually that other copy gets mutated. And so if you can imagine the scenario on the right, that has to happen twice, but in the scenario on the left, it only has to happen once. And so that's why what we often see is that in people that carry these inherited mutations, they can get cancer at a younger age than those that don't carry them. And one thing that's been that's really come to the fore in the last decade or so is that these genes like BRCA2 and other genes that repair DNA, they're very frequently altered in that advanced setting. So actually, about a quarter of individuals with metastatic prostate cancer, if you look specifically in their cancer, they will have mutations in genes like BRCA2. And what all of these genes do is they repair damage to your DNA. And that's their job in normal cells. So BRCA2 is one of the things it does is actually repair whole breaks to chromosomes. It's part of a complex that recognizes that break and then stitches it back together. And same with these other genes, they're kind of involved in different aspects of repairing DNA. And the reason why a cancer wants to lose that is because then it can more rapidly accrue mutations. And cancers don't think, but they evolve. But you can think about a Darwinian, a sort of ecology system. The more complex and diverse it becomes, in a sense, the healthier it becomes, the more able it's to resist treatments or have sort of diversity within its population, that it can grow more quickly or develop outgrowths that can spread to other parts of the body. So cancer sort of like losing ability to repair DNA. So, this kind of discovery came in metastatic prostate cancer because it's so strong, a quarter of all individuals, and many of those patients will actually have one of the inherited forms as well. But it's also relevant for people that have localized disease, so disease that's caught before it spreads. So still about 10% of the patients that we see with localized prostate cancer will have these types of DNA repair defects within their cancer. And these genes are important for various reasons. So this is a data slide, and I'm sorry for that, but just to hammer home the points on it, the first one is that if you have a mutation in BRCA2, there's this personal risk of cancer. So you're at a higher risk of other cancers as well. There's also the familial risk, so children, brothers, sisters, and other relatives. What we also know is that individuals with these defects in their cancer, the cancer is more aggressive overall because it's able to accrue, it has higher mutation rates than the other cancers. And so what we see is that you're more likely to have a worse outcome on the standard treatments that we might do. So if we give an androgen receptor inhibitor in the late setting, a patient with a BRCA2 defect, it's going to come 3 times.
Code red, all clear. Code red, all clear. Code red, all clear.
Didn't hear the code red to start with. So on average, those individuals will not derive as much benefit from those standard therapies as someone who doesn't have it. Of course, it doesn't necessarily extrapolate to the individual. It's when you step back and look at the whole population level. So you can still have patients with these defects that just derive exquisite benefit, but that speaks to that overall heterogeneity. So we know poor outcomes, and then so that kind of extrapolates even early in disease. So we actually know that if you're on active surveillance and you have one of these variants, then you're at higher risk of upstaging from Gleason 6 to 7, for example. So kind of no matter where you look, it's associated generally with a little bit more aggressive disease. But what really has sort of pushed the scales into why we need to know about this in clinical practice is that we now have therapies that can exploit these defects and turn them from being a bad thing into potentially a good thing. And so the kind of the vanguard of this is what we call a PARP inhibitor. It's an acronym, but it's a class of therapy that exploits the fact that the cancer has lost an ability to repair DNA. And so it doesn't matter whether those variants are germline or they're somatic. What we call them is a predictive biomarker. So we need to identify these mutations in order to then give the treatment. So if we give it to patients that don't have those mutations, they'll derive no benefit and just will be exposed to all the toxicity of an extra treatment without any of the benefits. So what we need to do is testing to find the mutations, and then we know who's actually has a good chance of benefiting from it. And to give you, a little bit of an explanation why these work in patients with these defects in DNA repair genes, there's a really cool concept in oncology called synthetic lethality. And the idea is that cancer cells have lost the ability to carry out some basic processes in their cells. And what you can do is create extra stress in the cancer cells, and the cancers themselves will be exquisitely vulnerable to that, whereas the other healthy cells in your body will just be able to deal with that stress like a healthy cell. And in this context, what it's about is causing more DNA damage, in fact. So in a cell with a BRCA2 defect, as I mentioned, it's lost its ability to repair those breaks in the chromosomes, right? And so instead what it does is it kind of relies on a patchwork of kind of incidental DNA repair mechanisms to sort of stitch things back together. It doesn't do a great job of it, but it does enough to sort of patch over the cracks and survive. So what you can do is come in and inhibit one of those redundant pathways. And for all the rest of your cells in the body, it doesn't matter because they've still got BRCA2 functioning to repair those double-stranded breaks. But the cancer cell doesn't have BRCA2 anymore. So what you do is you then overwhelm the cell with damage. So that's a synthetic lethal approach. This was discovered in cell lines many years ago and converted to a treatment that's used in ovarian cancer, breast cancer, and now prostate cancer. So, that's the reason why we do testing. So we want to be able to find these individuals so that we can give them a treatment that specifically actually works in their DNA repair defective cancer. And there are other treatments that actually now exploit DNA repair defects as well. So immunotherapy is a class of treatment that works in only a small proportion of people with prostate cancer, but it's specifically those that have defects in their ability to repair point mutations, so single mutations in the DNA. So different DNA repair pathway. And when you've lost that, you accrue loads and loads of mutations, and it means that your immune system starts to see the cancer because it's so mutant that it starts to recognize it as foreign. But in most people with cancer, your immune system is a bit exhausted, and so even though it may see it, it can't do anything about it. So the immunotherapy kind of takes the brakes off those immune cells and allows it to attack. But if we give immunotherapy to every patient with prostate cancer, 97% of them are going to derive no benefit and are just going to be exposed to some of the really bad side effects that come with immunotherapy. So again, we have to do biomarker testing to find the 3% that do have these variants, and then those are candidates for immunotherapy. And this, I think, is these treatments are at the vanguard of an era where genomic medicine or genomic tests are part of our toolkit for how we decide what treatments are best. It's not the answer to everything, but it's another tool that can help with being more precise in the way that we treat people. So what's the process here in British Columbia? How do we get testing done? I've recently taken a new role. In addition to the academic ones that we spelled out at the start, I'm now the scientific director of our clinical cancer genomics program. So it's not just for prostate, but for all cancers. And so I've got a role now in actually how we deploy genomic testing across our province, so both genetic and somatic testing for anybody with cancer. And it's going to take a while to implement a new strategy, but one thing we're really trying to do is move from just, at the moment we have quite narrow tests that are only eligible for, only some patients are eligible for in some cancer types, to do much more universal testing, and hopefully eventually move to a scenario where all patients with cancer have some form of both genetic and somatic testing. It's going to take some years to implement, and we need new tests, and we need extra funding from the government. But that's part of kind of my vision with this job. So at the moment, we still do have some tests available that provide the kind of basic information I'm going to walk through in a minute. But I hope in the future that we have more and more data to better arm physicians and patients with the information that really could be critical for treatment planning. Here was AI image again. I asked for a patient trying to navigate the complicated, I don't know why they're holding a DNA strand or what all these pills are, but I absolutely recognize that this is complex. And one of the reasons it's actually complex is because even physician training, like if you take urology at the moment, urology residency, for example, 5 years long, but it doesn't include any modules on genetics and cancer genomics, for example. So, even for oncologists and physicians, this is a challenging subject to wade into. And it evolves so rapidly, right? Year on year, there's new information, new tests, new genes, new treatments. And so, for everybody involved, it's a complex scenario. And so, increasing education is going to be really important as we increase the amount of testing we do. So we, across Canada, have tried to put together guidelines, primarily aimed at clinicians, but I think it's really important for patients and advocates to also be aware of these guidelines. It's the Canadian Urologic Association guidelines. They're public. You can Google it for prostate cancer genetic testing. And what these guidelines are supposed to do is synthesize together evidence from around the world to sort of a recipe for a physician to say, what's the minimum that I need to do in a patient? And so what these guidelines state at the moment is that germline testing, so for BRCA2 and those other DNA repair genes, should be performed in all prostate cancer patients with metastatic disease, so it's spread beyond the prostate. And that this should be done as early as possible in treatment planning. So as soon as you know that there's metastatic disease, it's worth starting that genetic testing process. And there's a kind of core set of minimum genes that are important to screen. But we also recommend that this be performed in selected patients with localized disease. I would hope in future we can move to all patients, but at the moment, we need more resources to do that. But so what we do is, if you have a positive family history of related cancers, and there's a specific formula for this, but essentially it amounts to relatives that have had prostate, breast, ovarian, pancreatic cancer, particularly first-degree relatives, so a parent or a brother or a sister. That would count as a strong family history of related cancers. But also if you have high risk or very high risk localized disease, so high Gleason grade or high PSA or other metrics that will put you in a higher risk category. The point in red is really just to say that germline testing can look at different genes than in somatic testing, which is another reason why we strongly recommend that everybody that's eligible have both germline genetic testing and somatic tumor testing on their cancer. And then so for somatic testing, we recommend that be performed in patients with metastatic castration-resistant prostate cancer. So that's at the later stage, and the reason why we recommend it then is that's when you would use a PARP inhibitor. And so that's when we really want to know for selection of therapy. But again, we want to perform testing as early as possible. So what we try to recommend in British Columbia is that if a physician thinks there may be the possibility at some point in the future that the disease may progress to castration-resistant state, and may be eligible for a PARP inhibitor, it's better to try to get that information early so that you're armed with it for later on. What we don't want to do is get to the point where you want to make the decision and then realize it's going to take a month to get results, or you don't have the material available. So it's much better to try to plan this as early as possible. And so we recommend that this is done on archival prostate tissue, ideally. So the tissue that was collected when prostate cancer was diagnosed can be retrieved from a pathology lab, and it's sampled, the DNA is extracted, and it's sequenced centrally at BC Cancer. Yeah, please go ahead.
I have prostate cancer. After the operation, I just said yes.
Mm-hmm.
So, where the outcome from? Part of your research was that?
So everything I'm talking about here is part of the clinical pathway. So it'll be different to the research. So if you have a surgical procedure done related to cancer, the primary use of that tissue is for cancer care and for pathology and diagnostics. So the kind of best parts of that tissue will be preserved and kept within pathology labs for up to 25 years or so. And so that's the material that in this context, if we needed to perform testing, that we'd go to the pathology lab that's holding the piece of tissue, and we'd request it to be sent to the genetic testing lab. We'd take a piece of it, and then that piece of material be sent back to pathology.
But it's only those patients that have said yes.
No, so it's routine for anybody that has surgery. The hospitals that do it have to bank the tissue. So any research is kind of on top of that. So if for example, you have your prostate removed because you have cancer, and you consent at the same time to a research program that might be studying the cancer tissue, extra pieces of the cancer tissue, there's no extra surgery associated, but the pathologist and future genetic testing don't need the whole prostate, but so extra material will be put aside for research. But that would only be done if individuals were consented to a specific research process. So anybody that's had a prostate biopsy done, or a radical prostatectomy, or a tissue biopsy done of another piece of disease, whether that had cancer in it or didn't have cancer in it, it will be preserved in a hospital archive somewhere. And that's what we rely on for tissue testing. So nobody has to have consented into a previous research study. Any research is totally separate from this. Does that make sense? Yeah. So we will rely on that we call it archival tissue because it's in the archives from across the province. So occasionally there'll be a patient from, say, out of province or out of country. Often we'll still try to track down the original tissue there. Sometimes it's not possible, and then you might say, well, now we need to collect a fresh biopsy. In a patient with metastatic disease, that might be from a bone metastasis or a lymph node.
I don't know if this works.
I think it should work, yeah. Yeah.
How long do they typically keep these tissues? Like, I've had biopsies over the last 20 years or so.
Mm-hmm.
So, and I would assume they're all different. No cancer, cancer, right? Like that sort of thing, right?
Yeah, so they'll keep the tissues. It depends on the individual hospital policy, but it's for a long time. Pathologists don't like to give up tissue. They sort of collect it, right? So they'll keep it for a long time. Typically, it's 25 years or so. Now that tissue might get moved off-site into warehouses, but what it's put into these formalin blocks. So first of all, it's dipped in formalin, which preserves all the material, and then it's put in a paraffin block, so like a wax block. So it's completely sealed from the outside air and damage. it does still begin to degrade over time. So if we retrieve tissues that are 25 years old, the success rate of profiling won't be as high as if it's from last year. But in theory, those old materials are available. Of course, it also depends how much cancer is actually present in the material. So, sometimes you might only get a tiny bit of cancer material, and that might not be enough to do the genetic testing downstream. So the other option that we have in the later setting is to do circulating tumor DNA testing, which is what my lab has pioneered. So that's where you use a blood sample to actually get at material from the cancer. So cancers are super inefficient. They're turning over all the time, so they're dying, but they're proliferating a little bit faster than they die. But all the detritus, all the kind of material from that turning over population just kind of bleeds out into the surrounding tissues and the bloodstream. And so what this means is that some of that DNA, some of the cells, some of the proteins from the cancer is actually present in a small blood draw from a patient with cancer. We call it the liquid biopsy. And in prostate cancer, it's particularly relevant for those with advanced disease, where we can't get tissue or biopsy material. So we can actually study the DNA that's in the blood from the cancer and find the mutation status of, say, BRCA2. And so what we have in British Columbia is actually a test that was developed in my research laboratory that is now operated by the clinical genomics lab at CGL. And it means that if people don't have tissue available, they can have a ctDNA test to look for those BRCA2 and other gene alterations. And that's something that I really want to focus in the coming years on. How do we make better versions of that test clinically available? Because the one at the moment is based on older technology. But also, how do we extend that to more cancers? So we're the only province that can do this, and we only do it for prostate. So how can we make sure the rest of Canada can do liquid biopsy testing, and how can we make sure that other cancers beyond prostate can benefit? And I'm really excited because more and more genes will be tested in the future. I talked specifically about a handful of genes, but there's so many more that are relevant for prostate cancer. This picture on the right-hand side is kind of just a schematic indicating that there's lots of different classes of prostate cancer at the genomic level. And we think from the data that we see when we do research studies that many of these classes really do influence how the disease will respond in the context of therapy, or whether it will be aggressive or not aggressive. So we really feel that people should be armed with lots of information about the cancer, but we have to prove utility for the extra information at the moment. And that's a large part of my research program, is actually proving that to have the extra information does benefit the patient ultimately. So I've kind of touched on this, what are the, historically, what do we use for genomic biomarkers? We use whole blood testing. So that's not the liquid biopsy, the ctDNA. We're using all the white blood cells in the blood. That's telling you about your inherited mutations. So if you need to have a germline test, you typically provide either a blood sample or saliva. And then for tumor tissue testing, we use, typically it's that archival material. And that does fail in some patients because it can be a small amount of tissue. One thing that's been, a disappointment in some regards is that in other cancers, you can access metastatic lesions more easily. In prostate cancer, because it typically metastasizes to bone, which is the image on the right-hand side. That's a man with lots of bone metastases, those black splodges of the cancer growing from a bone scan. It typically is bone predominant, or it's in inaccessible lymph nodes. So it's not a disease we can easily biopsy once it's spread, which is one of the reasons why circulating tumor DNA has been of most pressing importance in prostate cancer. So as I mentioned, cell-free DNA, circulating tumor DNA is a more easily accessible analyte in prostate cancer. So it works on the context, as I said, that the cancer is shedding DNA into the blood, Actually, all of us have cell-free DNA in our bloodstream. It comes from our normal cells turning over, but in a person with cancer, a small proportion of that is cancer-derived. And now that technology has advanced so much, we can actually access that and specifically study it. One of the reasons ctDNA, circulating tumor DNA, is so exciting across oncology is because it actually has many different uses. So one context is actually after patients that have been treated for presumed localized disease across different cancers. So let's say you come in with a localized breast cancer, and 6 months later, you can see ctDNA in the blood. It means that you didn't get all the cancer. And the opposite is also true. So you don't see ctDNA, it means perhaps you did get all the cancer. And so there's a lot of excitement to use ctDNA presence-absence as a binary variable to help understand when we should intervene in people that have had local treatment. In prostate cancer, maybe that's not the lowest hanging fruit because we actually have PSA, which does a reasonable job of detecting recurrences early before you would start to see things on scans. So when should tests be ordered? So as I mentioned, it's really as early as possible. And if any of you think you're eligible, you should be, I think, talking to the physicians about this. The earlier, as soon as it can be reimbursed, I think the earlier is better. For germline or tissue testing, of course, it can be done at any time because you can provide a blood sample for germline testing at any time. Your tumor tissue can be requested from a hospital at any time. There's no specific points in your disease course that needs to happen. But for the liquid biopsy tests, the ctDNA tests, those only work well at times when disease is actively progressing under treatment. So it needs to be at a time where the cancer is actually proliferating quite a lot because that's when it's shedding the most DNA. And so you can kind of see that in these bars at the bottom. The same is true for a metastatic biopsy because you can only see the metastases at the times when they're actually growing. And that's the time we would do a tissue biopsy. That's the time when we would do a ctDNA test. So it's a little bit different, the timing of the testing, depending on what you're actually going to study. But of course, most of the time we are looking at either the blood for the germline or the archival tissue that was collected at diagnosis. So traditionally, how would you get this done? Well, in the old days, it used to be that an oncologist or a urologist would have an appointment with the patient and think maybe this individual should have genetic testing done, and they would then refer the patient to the hereditary cancer clinic at a given jurisdiction. So a specific clinic that looks at people who may have inherited mutations. And then germline testing would happen, and that patient would be seen entirely within the hereditary cancer program for your given hospital. But in fact, what happens now is what we call mainstreaming, which is that people with cancer are seen by an oncologist or urologist, and then those physicians can order the test themselves. So it doesn't require this separate referral to the hereditary cancer unit. And then what happens is only in the case of a positive result are patients referred on to the hereditary cancer specialists. So this has been a big improvement in the way that we practice genetic medicine and genomic medicine, that the requisition forms for testing are now within the electronic medical system. So they're within Cerner if you're seeing a BC cancer, and the oncologists can pull up the genetic test requisition and the somatic test requisition and fill them in, and they don't take very long to do. So they can order the test. So what we do at BC Cancer is that if you have metastatic cancer of any kind, of any state, you're eligible for testing. And also, as I mentioned, those kind of selected localized disease indications. But so we try to do both tissue testing and germline at the same time as early as possible. So even in those patients where perhaps their disease won't progress to castration-resistant disease, we still want to have that information as early as possible. And then if tissue doesn't work, then we reflex to using ctDNA at the time if the disease does progress. And so we deployed this new algorithm in May 2022. And since then, we have tested over 2,300 patients with advanced prostate cancer. So the initial estimates were it would be a few hundred, but oncologists really bought in, and there's been great uptake of the testing program, and it's probably only going to increase. So I think this is my last slide. Yeah. So I just want to acknowledge that there are many, many problems with the way we do testing at the moment. So it's a kind of work in progress. Guidelines are constantly changing, so there's new information all the time. Our tests are probably not as comprehensive as they should be. We need to look at more genes. We also obviously need to look at more patients. And not all of the alterations that we know are relevant may be identified by our current tests. So that's kind of a big reason why I want to get involved, to help improve the way that our tests are actually designed. We know that there can be what we call false negatives, so cases where the cancer itself is positive, but our test gives a negative result. And that can happen, for example, if you have only a small amount of cancer in the specimen. You think you're testing it, but you're actually not. It can happen if the cancer evolves over time. So sometimes that primary nodule, the initial cancer, might be quite distantly related to what presents later on in the metastatic setting. And in the meantime, that cancer acquired some extra variants that weren't there in the original tissue. So there are still limitations with our testing. And I think this text at the bottom, I always like to say, well, in the clinic, we want to binarize things. We want to say, you have cancer, you don't have cancer. Your test is positive, your test is negative. But the reality is biology is not binary. I'm probably standing here with some cancer in my body somewhere. Very small nodules, very slow growing. Maybe my immune system will clear it up, right? But I'm not a cancer patient. But biology is not this black and white binary spectrum. It's a binary category. It's a spectrum of complexity. And so our genetic tests are aimed to try to create these categorizations. You end up forcing things into one bucket or another. But I think we always need to remember that individuals, we're not these binary states. And so that's ultimately one of the biggest failure with any kind of diagnostics. And so I'd just like to point it out because that's just a fundamental limitation. No questions. This is a audience of cancer patient advocates giving rousing applause to happy scientists who finished a presentation on cancer genetics. And I don't know if you notice here, I only saw this just after literally just as I was flicking through the slides at the start, but the tool is spelt cancer genetics. So I really am not worried that I'm going to lose my job anytime soon. But thank you very much for listening, and if you have questions, happy to answer them.
I've got you. So I'm speaking for somebody else. So first question. Is circulating tumor DNA an alternative to PSA testing for detecting reoccurrence of prostate CA?
Yeah, so that has been a very exciting area of research in some other cancers. So actually in the urology sphere, bladder cancer, there are now approved tests in the US that will detect bladder cancer after bladder removal. With better sensitivity than our imaging-based approaches. The same is true in some other. In prostate, there have been very few studies that have looked at it. And I think one of the reasons is that PSA is already quite a good indicator in that setting. And so I'd suspect that there will be some gains for having ctDNA information as well. But it's going to be a modest gain on top of what PSA already provides, I think.
Okay. And if I can just ask the second question, then I can turn the button off. What is the purpose, or in brackets, or the benefit of cfDNA testing of a patient with metastatic prostate CA?
Yeah, so I think. Oh, sure. The question was, what is the are there any benefits to ctDNA testing in a patient with metastatic or advanced prostate cancer? So yeah, it absolutely provides another layer of information that you would not otherwise have. So what it's telling you is about the lesions that are spread around the body rather than just the lesion in the primary site. And that can give you more contemporary information on disease, right? How has it evolved over time? What are the mechanisms of resistance to treatment if they're there? It can survey on multiple sites at the same time. So it is giving a sort of a different flavor of information than if you test a single region of tissue. Now, it comes with limitations, though, as well, because sometimes the amount of ctDNA in the blood can be very, very low. And you don't know that up front. You know, when you have a cancer piece of tissue from a patient, the pathologist looks down the microscope and they can see exactly where the cancer is and where it isn't. And if they have a piece of tissue that doesn't obviously have much cancer in it, they won't send that for genetic testing. If we take a blood sample for ctDNA testing, we don't have the luxury of doing that. We can't look down the microscope and see the cancer DNA. We only know it's cancer DNA after we've tested it. And we can see the mutations, right? So that means that sometimes we can test ctDNA, but it only gives you a tiny amount of information because there's very, very low levels. And we try to control for that in the way that we report testing, but that is kind of a limitation to ctDNA testing. Other questions? Yep.
Just a clarification on that particular point. How does it help the patient? Is it helpful in terms of the choice of treatment that you would use? Or for the doctor, I mean?
So the question is, how does the information specifically from ctDNA help the patient? So at the moment, we probably wouldn't order both a ctDNA test and a tissue test at the same time. So there's sort of alternate methods to get at the same information. Like we want to know the status of BRCA2 or other genes in the cancer. And so both of those analytes give you the opportunity to find that out. So I think ideally, both of those information together would give you more than one on its own. But at the moment, we do just do one at a time for the somatic testing. So it might be, for example, an individual where the prostate tissue is held in Alberta, but we need a test result in 3 weeks. And so we can't go through this process of requesting tissue. So instead we use the liquid biopsy approach, where it might be when there's been 20 years since the tissue was collected and we think that old tissue is not going to be representative of the disease we have today. So we need a ctDNA test. So there's no kind of singular massive advantage of one over the other, but they're both trying to give you the information of is there a mutation in the cancer that we can target with a therapy. Does that make sense?
Not really.
No?
The question was more like, so if I had that information and I'm a doctor, does it help me determine whether I should send this patient for a PARP inhibitor, immunotherapy,
Yes.
like a Pluvicto type of
Yes.
treatment, or not immunotherapy is like a Provenge type of treatment, or Pluvicto?
Yes, absolutely. So the oncologists are ordering those tests to understand if the disease would benefit from a PARP inhibitor, for example. So absolutely, the information from those tests will influence the choice of treatment made by the physician. And actually, it goes a little bit beyond that as well, because as I mentioned, we know that if you have one of those mutations, the disease can be more aggressive than if you don't. So it might also slightly change your management plan. So you might say, well, rather than getting a checkup every 6 months, we're going to do it every 3 months. So it's they influence the actual treatment choice, but also potentially management plans as well. Any other questions? Yes.
Hi, I was 5 months ago, had a radical open prostatectomy. My father passed in 2016 from prostate cancer, metastasized. do we need to enroll into this program? Both of our tissues are here, VGH. Do we need to enroll in this program, or is it kind of automatic?
So this would be a question for the urologist that is treating you. So they can order the genetic test themselves. They can access a requisition form. And if they can't, they can reach out to any of the oncologists at BC Cancer can facilitate that. So that should be something that, so you would be eligible on the basis of your family history. So very sorry to hear about your father. So absolutely the genetic testing part of that you would be automatically eligible for. But yeah, it would be you could have a conversation with your physician.
Okay, that'd be great. We'd be looking for the next generation for protection for them.
Absolutely.
Yeah, great, wonderful, thank you.
Any other questions?
How do you know that you are qualified for the testing, or anybody who has prostate cancer are qualified?
So anybody with advanced disease is qualified. I think if you're at all in doubt about it or you're interested in it, it's a conversation to have with your oncologist or your urologist. So I think because this is quite a new program, we as need to be our own advocates here as well. And so sometimes, especially in community practice, not all of the practitioners are aware of the latest changes to guidelines. So it can be helpful, I think, to bring it up, because not everybody may be aware that there's a pathway to get the testing done. But yeah, I think it's a conversation you can have. They will be able to understand if you're eligible according to the guidelines in the electronic medical system.
So we have to ask our specialist doctor
Yeah.
under your case.
Yeah, that's right.
Yes, thank you very much for a very interesting presentation. I'm interested in the germline in particular. And I've just gone through a process. Actually, my sister had some issues, and I went through BC Cancer, blood test done, and this Lynch syndrome was ascertained. So I'm kind of familiar with the process. But it started with her, and it went to me and to my siblings. And I just wonder, with the germline itself, I got my biopsy done a couple of years ago, ended up with a radical prostatectomy. And the germline, I wonder, why isn't it done when a biopsy confirms? I think that's the optimum time to do a germline and your somatic at the one time, rather than having to now go back to my urologist and then ask for this and go through the process with hereditary cancer.
I absolutely agree. I think if we can design the system again or reimagine the system, it's at the point of first diagnosis. That makes the most sense. That's when we can maximize the chance of having good data coming from that material. The reason why it hasn't been like that is because the old model for cancer testing was to match with drugs. So it would only be done on patients that were theoretically eligible for a given treatment. So you wouldn't give a person who was having a radical prostatectomy wouldn't be eligible for a PARP inhibitor, so you wouldn't do the testing. And similarly, if you were looking at germline, there used to be quite, I wouldn't say rules, but a consensus about when it makes sense to deploy population level testing versus very targeted testing. And so it was about the prevalence of a certain mutation. So in prostate cancer, in localized disease, only about 2% of men will have a BRCA2 mutation. So, there becomes like an economic question about how many you have to test in order to find positives. In a metastatic setting, it's sort of 5, sometimes higher percent. So I think we're going to move in the next few years to a model where that you describe, where we test more and more patients. The problem is there's 30,000 patients newly diagnosed with cancer each year in our province. So it's a large number, and we have to we have to take steps to get there rather than immediately deploying to everyone. But I really hope that we can head towards that.
Yeah, thank you. Just wondering on your sort of recommendation and your thoughts in terms of if that material has been collected and it's now residing somewhere in some hospital, as time goes on, it potentially degrades.
Correct.
So is it something that you would say the quicker you have a conversation with your urologist, the better, rather than wait another 20 years and then ask for it?
So you're right, it does degrade. The process is quite slow, and a prostatectomy tissue is not at as high a risk as a needle biopsy tissue. So the needle biopsy is already quite scant and small amounts of material, whereas prostatectomy, you have the whole prostate. The challenge is the way the reimbursement works at the moment. So tests will only be paid for if the patient is eligible according to the guidelines. And so the scenario you're describing, that individual wouldn't be eligible at that time for the tests because they don't match the guidelines. So even though even a physician may think, yeah, this is the ideal time to test, it's not possible for them to order the test at that point because it wouldn't be paid for through the system.
Question, I don't want to hog the microphone here. You mentioned a high risk with respect to being eligible for this this germline testing. What sort of Gleason score would you be saying would be, tips the scale to a higher risk rather than
there's multiple cats. So Gleason score of 8 is considered high risk, 8 or above. And remember, it's risk is defined about risk of recurrence downstream, right? So, and then very high risk is typically 9, 10. But there's more than, so you can have a lower Gleason score, but say a very, very high PSA, and that would also put you in a high risk category. So it's not just Gleason alone, but yeah, there are some variables, but it sounds like family history for you would qualify you for the genetic testing element anyway. Right, there was a question at the back, which thanks.
Know that is there any specific age limitation for diagnosis prostate cancer in young generation? For example, if a dad has prostate cancer and also in metastatic station. So for his son, what's the situation? Is there any diagnostic test that could help him to diagnose as soon as possible, or any specific age limitation?
So the question is about what age you might be eligible for prostate cancer screening. If you have an affected parent. There isn't really, we don't do population PSA screening in British Columbia. It kind of fell out of favor around the world, a decade or more ago when we realized we were overdiagnosing a lot of people with very indolent cancers, and then that was causing lots of strain on people to have their prostates removed when it didn't need to happen, and the financial burden and the anxiety of cancer diagnosis. But the problem was that we were catching some cancers early, and so we were curing people that would otherwise not be cured if their cancer was not found till late. So, but unfortunately, it was something. I think it was in the range that we'd need to diagnose 80 odd individuals extra with cancer to save one. Now we know that we don't need to just deploy population-level cancer screening. We can do it in a PSA-based screening. I mean, there are models to do it in a more refined way. And so there isn't a systematic process for that at the moment. But people are like me are working on the problem at an international level. I think it's if family history is really strong and you have a family doctor, then that's the place to have that conversation. And at age 45, I think it's reasonable to have PSA testing. I think for most people, the important thing to understand is where your baseline PSA is. So you can show up at 65, 70 and find out your PSA is 5, but maybe it was also 5 10 years ago. And so whatever trajectory that is on is quite flat. So I think, yeah, it's a really good idea to try to get a baseline for people that are otherwise, unaffected. And then you have kind of a start to monitor it over years. But I think, if you have a really strong family history, that a PSA test is very cheap, and I think that's a conversation you can have with your family doctor about whether that's worth ordering.
About testing for tissue from prostatectomy. What is the testing for that had radiation therapy? Is that PSA only, or?
So if you've had radiation therapy, yeah, you're right, the prostate was not removed and was ablated instead, but you'd still have the original needle biopsy material from the diagnosis. So normally most people that go on to have radiation therapy initially had a prostate biopsy to actually identify the cancer in the first place. There's a small proportion of people that would have what we call a working clinical diagnosis, which is where, for example, somebody would have a very, very high PSA and they have, cancer in their bones on a bone scan, and we kind of make the leap that this is probably prostate cancer, and we don't want to delay treatment by worrying about biopsies instead. We need to start treatment because normally those people are very, very symptomatic. In those small number of cases, maybe we don't have that archival material, but even for most of the people that get radiation therapy for their prostate cancer will have had a biopsy done, and that's what would be used for genetic testing. Any final questions before we close? Yeah. Oh, yeah. Say again, sorry?
What is the advantage of doing the testing?
The advantage of doing the testing? So why do we test? Let me go back. So there are 3 reasons we have to know about the status of these genes in people with advanced disease. So the first is that you may have family members that are at risk of cancer. So that's kind of, to some extent, it's an altruistic thing, right? But they could maybe benefit from having the knowledge earlier. The second is that we know that disease that has these variants, these mutations in it, is more aggressive than disease that doesn't. So we would consider monitoring those patients more closely, perhaps making more intensive treatment plans to try to quash the cancer more. And the third is that we have therapies that are matched to the mutations, and we can't give those therapies unless we know the mutation is present. So we find the mutation, and then that means we can now give the treatment, the PARP inhibitor, in the context of what we were talking about earlier. So really, there's 3 major reasons. Does that make sense?
One question. What causes the prostate cancer?
What causes prostate cancer? Yeah, that's a whole nother talk, I think. It's a complex etiology, so to say that it's many factors cause prostate cancer. What we know is that if you do autopsies on men that die in their 90s of kind of other things than prostate cancer, almost all of them will have some small cancer in their prostate. And so it's kind of, to some extent, inevitable that if you live long enough, you will get a form of prostate cancer. Now, in most of those, or all of those people, it never grew quickly enough to ever be a problem, or at least not a big problem, right? So we know that it's sort of almost incidental to aging in most people, but then there are aspects that can make that get into kind of earlier prostate cancer, and that's to some extent like your genetics. Did you inherit a mutation that predisposes you to cancer? Does your lifestyle contribute? We know that like obesity and kind of Western diets are not ideal for in terms of causing prostate cancer, exercise and healthy eating, healthy living is a factor as well.
What are the symptoms that if you have prostate cancer? What is the first symptoms that you will analyze it?
I mean, there are many. Some people will almost not experience any symptoms, and will get diagnosed incidentally on the basis of a PSA test. One of the most common is kind of urinary symptoms. So, peeing frequently in the night is a common one, right? Like
this is what happened. I pee frequently at midnight, so this is my symptom.
Yeah. But there are many causes for that other than cancer, because the prostate grows slowly over life anyway, and what's happening is it's taking up the space where your bladder is, and so it's making the bladder smaller, which means that you need to pee more often because there's not so much space in your bladder anymore as there used to be. But that can happen just because of benign growth in the prostate, not because of cancer. So it's many of the sort of symptoms of prostate cancer are not specific to cancer, unfortunately, and even high PSA, right? It's not specific to cancer. We don't have like a cut and dry symptom. We say, okay, that person definitely has prostate cancer, unfortunately.
Sorry. So in the case of a parent, a dad, having had a radical prostatectomy and has 2 sons, are they eligible for a germline test for the risk of themselves getting prostate CA?
So only if the person with cancer is found to have one of those variants. So in the context you're talking about, if that...
It has to predate the sons getting anything done.
Yeah, exactly. If the sons don't have cancer and are not otherwise eligible for testing, no. But what the hereditary cancer program does is, so once we have a sort of positive result, so let's say we find a man with an inherited form of the BRCA2 variant, his family members would be offered what we call cascade testing.
Right.
They don't have to do it, of course, that's an individual choice, but they will be offered the chance, okay, we know one of your relatives has this mutation, do you want to have testing done? And most of the time they do, but it's a personal choice, of course.
Great, thank you.
Yep, absolutely, go ahead.
So I'll take myself as an example, for example. I probably won't be eligible for that test. So it's a chicken or egg problem, because then my daughter can't go do a test as well, wouldn't it?
Yeah, I think the system is not perfect in that regard. I hope that, and our hereditary cancer program is putting so much pressure on the government and other authorities as well to help change the way that germline testing is done. That's something that there's an army of people thinking about it as well, because ultimately if we can find all the people in our population with these predisposing variants, we will drastically reduce the impact of cancer. Absolutely. Yeah, prevention is the best way forward. So yeah, exactly. But prevention and early diagnosis is kind of the best way forward. I think that you're right. I wish we had that right now, but we can work towards it as a group, I think. Time for maybe 2 or 3 more, and I've got to pick up one of my kids, unfortunately.
Yeah, thank you. Quick question. Again, going back to this Lynch syndrome report that I got, it indicated that they had tested 71 genes in order to come out with a diagnosis. For prostate cancer, I guess the number of genes perhaps are less. So is the test to expect a result if you do get it? I have to wait about 4 months for the report to come for that Lynch syndrome test. What's the normal turnaround time for a blood sample to an actual report?
Yeah, so it depends on the urgency of the test. So oftentimes when we do the germline test, it's not considered urgent by the system because it's not necessarily like limiting the care that you're receiving right now. So in theory, you can turn a test around like that in 1 to 2 weeks. Right, that's what's possible to do. So even though we might, the number of genes doesn't matter in a way because you test them all at the same time. And so you can have small panels or large panels. And you're right, for prostate cancer, we still might use those larger panels, but only report out on a smaller number of the genes, the ones that are actually relevant for the prostate cancer. But we'd still actually capture all of that information. So there are tests, genomic tests in lung cancer where we have to know inside 1 week because the patient's condition is critical and they need to know which treatment there must be. And so it's absolutely possible to do it quickly. It really depends on the kind of clinical scenario. I think you had one at the back there, yeah.
If somebody doesn't have the BRCA gene and still wanted a test, are there tests available in the public or the private market?
There are in the USA. I don't actually know to what extent they can be ordered here, but there are genetic tests that will inform on 70, 80 odd cancer-associated genes. The ones to avoid are what I call like your recreational tests, which is things like 23andMe. So they may claim to look at your germline, but they only look at very, very specific things, and they should not in any sense guide medical decisions. I think there's a company called Color Genomics, there's one called Invitae, there's one called Ambry. They've all got huge Google footprints. Like if you Google genetic testing, they'll probably be up near the top because they've paid Google to be promoted. And certainly they're being ordered by individuals in the USA, but we can't order them through the healthcare system here. Any last burning questions before we close? Well, thank you for really good engagement. Very, very much appreciated.